Okay, guys, so now we're going to get started on antidiarrheals and laxatives. I changed the background. You guys like the brown? Hence diarrhea. All right, so it's like code brown, right? You'll hear that in the hospital. Code brown. All right, so we'll get started. Yeah, I'm goofy. All right, so antidiarrheals and laxatives. So what is diarrhea? Well, it's abnormal frequent passage of loose stool, or it can be abnormal passage of stools with increased frequency, increased fluids. It could be mucousy, more watery, and weight, or with increased stool water excretion. So there's different types and there's different reasons why people have diarrhea, but technically diarrhea is diarrhea. Just for a side kind of fun thing, Google the Bristol stool chart, Bristol stool chart. It's actually used in a GI departments, and it's a true thing. We kind of make jokes about it. I have a drug rep give me the Bristol stool chart, and I completely embarrass my kids by keeping it in the bathroom. So it's basically tells you it's a helpful tool to just figure out if your stool's normal or if you're having diarrhea or not. It's like type 1 type 7. So anyways, we'll move on here. So diarrhea can become a chronic thing, or it can be an acute thing. So if it's acute, it's usually 3 days to about 2 weeks. It goes away. You're healthy and it just comes on and you don't know why, and then it just goes away and it never comes back. You may end up going to the doctor and we just tell you to follow a brat diet, which is the banana, rice, applesauce, clear liquids, which are apple juice and toast, but then eventually it'll just end up going away for some unknown reason. Now, diarrhea lasts more than 3 weeks. You have to start worrying about electrolyte loss. Many times you'll have extra symptoms that go with that, such as nausea, vomiting, watch for weight loss, you start getting weak, or fever. So to split up the different ones, acute many times is viral, which a lot of times the acute, less than 2 weeks, most of the time it is viral, or nutritional. But sometimes it can be bacterial, drug-induced, nutritional, protozoal. So like drug-induced, remember we talked about metformin in for the diabetes, that can cause diarrhea. Now, chronic diarrhea, greater than 3 weeks, can be from other things, like your body's telling you that something's wrong. So tumors, Crohn's disease, and ulcerative colitis are inflammatory bowel disorders. Diabetes, hyperthyroidism, remember things are working hyperactive, so you can have some diarrhea, and irritable bowel syndrome, which we'll hit on also. Now, I suggest you do flashcards for these two. For this unit in general, I would do flashcards because there's so many different ones to remember. So this is a type called an adsorbent, and these coat the walls of the GI tract. Examples: Pepto-Bismol, it's kaopectate, activated charcoal. Those are just some examples. So I'm sure you've heard of kaopectate and Pepto-Bismol. It's all over the counter, coats the wall of the GI tract, and it's supposed to bind to the bacteria or toxin that then eliminates through the stool. Some common side effects are you can have an increased bleeding time because remember it's got the salicylates in it, the aspirin, dark stools, black tongue, which I know I talked about on the previous slides, confusion, twitching, it's rare, but it can. Be careful with hearing loss. You want to be real careful with giving kids this. It's rare to have hearing loss, but it can happen. Tinnitus, the ringing of the ears, which would make sense if you're over using it with the aspirin in it. Metallic taste, and blue gums. A funny story about this is that I actually like the taste of Pepto-Bismol. Yes, I'm strange, but back years ago, I was pregnant and I didn't know that, and I was nauseous. And I had Pepto-Bismol, I swear, every single day for like a month until I realized I was pregnant. So it was I was throwing up. So I'm like, oh, I'll just take some more Pepto-Bismol. So I might have had ringing in the ears, although I was just so unaware, I had no idea. All right, so here's anticholinergics. These are things like Donatel and atropine. It's not something that we see too much. This decreases the intestinal muscle tone and peristalsis. So peristalsis, remember, like that's helping the stool move through your GI tract. So it slows the fecal matter down through the GI tract. So it's not used too much, but that is a class of medications for that. So think of anticholinergics. Remember, it can cause that dry mouth and then hence constipation. So it's supposed to slow things down, but can also cause urinary retention, hesitancy, now impotence meaning erectile dysfunction, headache, dizziness, confusion. So just know general. I don't expect you to memorize all of these other than the main things, which would be your which is not even in here, your dry mouth and how it slows things down. So it can cause constipation. Although if someone's having diarrhea, it shouldn't cause constipation unless you're overusing it or taking too much. Now we do know that opiates slow peristalsis. They also help relieve rectal spasms. So some examples are Imodium, Lamodal, this opium tincture, I've never given it. Codeine. You can also give Tocianex, which is your hydrocodone. They're not really recommended other than for acute issues. Really only used for mild symptoms. And it's kind of funny because I didn't realize Imodium was an opiate. So that's something new that I learned. Do not use these for a suspected infection. Do not use it prophylactically. So this is not something that someone should take every day for diarrhea issues. It's just something to use every now and then. Say you have this acute diarrhea, to take a dose of Imodium will be okay, or a couple doses, but that's it. It decreases transit time through the bowel, allowing more time for water and electrolytes to be absorbed. Because remember, what happens is if you have an issue, the peristalsis is either going to be overactive or you're not going to have the water and electrolytes that need to be absorbed into the bowel. It's just off balance. And so sometimes this can help by just slowing things down. These can cause drowsiness, sedation, which would make sense with opiates. I would think it'd be rare unless you took a lot of Imodium for it to cause that, but just think these other ones, codeine. I'd have to look up opium tincture. It's very interesting in this paragoric, so you don't have to know that for testing purposes. But know them though, because you have your NCLEX. Or keep these slides for studying purposes. Urinary retention, rash, that can happen with pretty much any medications, nausea, vomiting, and then the opposite can happen, constipation. As you know, there's opioid-induced constipation, which we'll talk about. Some other ones are called intestinal flora modifiers, and these are your probiotics that you take that you can get over the counter. So it supplies, because they say there's one theory that you lose missing bacteria because our gut has good and bad bacteria, but what can happen if it has good bacteria, we can end up losing the bacteria, and then the bad bacteria overgrow, and so this supplies the missing bacteria to the GI tract. So for example, C. difficile. We have C. difficile in our gut, but if you've heard of C. diff in the hospital settings, it's not a good thing to have, but yet we all have it in our gut. But what happens is if we have chronic diarrhea or run antibiotics that cause us to have diarrhea, it can actually deplete a lot of the other bacteria, and then the C. difficile bacteria will overgrow and cause an infection. Acidophilus, Lactinex, there's so many out there now. Align, there's all different types. I can't even think of off the hand, but there's a lot of probiotics out there. So what are we going to do with acute diarrhea? So it's very important to manage the fluid and electrolytes because they can get dehydrated pretty easily, especially with older people and young people. So you want to offer clear liquids. So a clear liquid would be an apple juice. And a lot of times we think that apple juice is going to cause diarrhea, but it really doesn't. It does not irritate the GI tract. Clear liquids does not consist of prune juice. As you know, prunes in general can cause diarrhea. Milk is not a clear liquid either. I even would not recommend coffee. So I would just stick with water, apple juice, or electrolytes. And I would also be careful with Gatorade because of the sugar content in it. Sometimes that can irritate it with the extra sugar, although it's giving them electrolytes. But again, it's, looking at the person, if they really need it or not. And obviously, if they're dehydrated, they need to be in the hospital on IV fluids. Okay, so ulcerative colitis and Crohn's. What is this? Well, these are, I'm going to show you a different slide here. It's an inflammatory bowel disease. Oops, here I'm get to my music here, but we're not going to listen to the music. Okay. All right. So ulcerative colitis versus Crohn's disease. They're both inflammatory bowel disease, but there are some differences. It's an autoimmune, genetic. And when you think of ulcerative colitis, it's limited to the large intestine, whereas Crohn's disease can develop anywhere in the GI tract. So Crohn's disease, just neither of them are really fun, or not fun diseases to have. But I've known a lot of people with Crohn's disease that have had multiple surgeries because of ulcerations and bleeding. The ulcerative colitis occurs in the rectum and colon, involving a part or the entire colon, whereas Crohn's, it's the end of the small intestine commonly. Crohn's may appear in patches, but usually ulcerative colitis is a continuous pattern. Crohn's disease may extend through the entire thickness of the bowel wall, and then ulcerative colitis, there's inflammation in the innermost lining of the intestine. About 30% of people in remission experience relapse in the next year of ulcerative colitis. About 67% of Crohn's in remission will have at least one relapse for the next 5 years. So Crohn's disease is far harder to manage than ulcerative colitis, although they're both not good diseases to have. Just to give you an idea, how it's genetic, up to 20% have a blood relative with it. Affects men and women equally. So there's a lot of people that are affected. It can occur anytime, but most often between ages 15 and 30. And obviously symptoms can range from mild to severe. So I just wanted to give you an idea of what that was going on with that. So I'll get this started again. So what's the treatment for these? So there's two things. There's sulfasalazine, which only reduces inflammation. And actually there's no cure for ulcerative colitis or Crohn's disease. So remember that. But sulfasalazine can reduce inflammation, and that's all it does. It doesn't do anything with your immune system. But people can be on it with the immunomodulator, the Remicade, for example. There's other ones out there like Humira, and there's many other ones out there, Symphony and things like that. But just keep in mind, the only one of this I'd like you to know is the Remicade, infliximab. It's not a cure, but remember, all these immunomodulators can increase risk of infections, such as TB. So you want to make sure that you're telling them to report. Do you have any fever, chills, shortness of breath, or sore throat? You need to report this immediately. Remicade is given the first dose, and then you get another one in 2 weeks, and then you get another one in 6 weeks, and then it's every 8 weeks thereafter that. If they need surgery, you want to have them hold off on a dose if they're having surgery, because remember, it decreases your immune system. Hopefully it won't increase the Crohn's exacerbation, but again, it's like weighing the risks and benefits. You really got to watch for that. But sulfasalazine, they can continue through the surgery. All right, traveler's diarrhea. So what do we do when we travel? I go to Nicaragua every year. So they give me ciprofloxacin to keep on hand. I've never needed it. It's a treatment, though, that can be used for common traveler's diarrhea. It's 500 milligrams twice a day for about 7 days. If you get diarrhea when you're traveling, many times it's just your body's not used to the food. It doesn't mean there's a bacteria in the food, but if it doesn't subside or it's very severe, you may want to start taking the Cipro. Pepto-Bismol has also been researched to be used as a preventative to help coat the stomach so bacteria won't adhere to the wall. That's just more of an FYI. And the thing is, you don't want to take any, the reason why we're talking about traveler's diarrhea is you don't want to take any antidiarrheals in case of an infection because it slows the peristalsis. So Pepto-Bismol, we're thinking more as a coating, that's as a preventative. But once you have diarrhea, you really want to stop that, and you don't want to take any other because remember, if you have an infection and you're slowing peristalsis, you're keeping that infection in there, and that's not a good thing to do. Irritable bowel disease is kind of one in its own. It's like a mind-body disease, and there's been a lot of research. It's actually been a newer diagnosis over the last 20 years. It can be a very frustrating disease, and it's not something you're going to die from. It's just very annoying, and some people have it so severe that they have a decreased quality of life. Some people can be constipation predominant, some people can have diarrhea predominant, or a mixture of both. So it just depends what day it is, what you're eating, but the mind and the body go together, and they're really finding that your serotonin level, that there's serotonin receptors in your colon, in your GI tract, as well as in your brain. So as we know, serotonin has to do with mood in the brain, and that's why we take some people with anxiety can take that serotonin reuptake inhibitors, SSRI, such as Zoloft, Prozac, Paxil, Lexapro. So it is commonly linked. So people with anxiety, a lot of times they'll have irritable bowel syndrome also. It can cause some crampy abdominal pain, but no blood is ever in the stools. If it is, it could be from hemorrhoids. If it's bright red, one thing I want to say about blood in the stools, this is usually how it goes. If it's bright red, it's usually coming from the exit because it has not had time to digest and change colors. The darker it is, the higher up it usually is. But you do not want to blow off any type of blood, even if it's bright red. But typically, there's no blood in stools for irritable bowel disease. If they do, then you need to look into that further. Many people end up going for colonoscopy because they don't know what's wrong with them, and they've been miserable for at least 6 months, or very frequently where they're just constipated for days, and all of a sudden they'll have diarrhea for days. And then they'll have the colonoscopy and it's normal. So it's kind of like one of those diagnoses, well, everything's normal, so let's keep a food and stress diary that relate with your bowel habits. Let's see if it's a irritable bowel disease. So many times it is. It's not an easy one to, it's getting easier to diagnose, I should say, because people are becoming more accepting of the disease. But a lot of times if you're feeling miserable, you really think something else is wrong with you other than irritable bowel disease. For these antidiarrheal agents, you want to make sure that you do a really good history, their bowel patterns, because it's really important to try to figure out which is the best agent or if they should even be on any antidiarrheal medications. You don't want to give bismuth subsalicylate, that's Pepto-Bismol, to children younger than 16 or teenagers with chickenpox because of the risk of Reye syndrome. You want to be careful in geriatric patients, those with decreased bleeding time, clotting disorders, recent bowel surgery confusion, because remember, these have the salicylates in it, the aspirin. Anticholinergics should not be administered to patients with a history of glaucoma, benign prostatic hypertrophy, so prostate enlargement, urinary retention, recent bladder surgery, cardiac problems, and myasthenia gravis. So it would be real important with the glaucoma, BPH. It's just contraindicated in that. It can make it worse. You're obviously going to tell them to take their medications how they should, and you're going to monitor their fluid volume status, make sure they're not becoming too dehydrated, etc. You're going to teach patients to notify their physician immediately if symptoms persist, if they don't go away, and you're going to always monitor, what's working, what's not working, are you feeling better, etc. So that is in on antidiarrheal medications. Let's start with laxatives now. Actually, I'm going to go to a different one here.